to welcome our two speakers today. So we have Marianne Young and Amanda Willis from the Kinghorn Centre for Clinical Genomics at the Garvan Institute for Medical Research. And they're going to be talking about my research results, which is an evidence-based process enabling research participants to access clinically actionable genetic information. And clearly, this is a topic of vital importance, not only for genetics research more broadly, but also it impacts upon the use of biospecimens for biomedical research in genetic studies. So I'll introduce both of our speakers. Marianne's going to speak first, and so many of you will know Marianne Young. She's a genetic counsellor and she's the clinical head of the Kinghorn Centre for Clinical Genomics, and she co-leads a genomic research and technology centre. She's a clinician researcher and her interests include novel models of genetic counselling and family communication, with particular emphasis on translation of research findings to clinical practice, and this is obviously highly relevant to her work on the My Research Results platform. So our second speaker will be Amanda Willis, and Amanda is also a genetic counsellor within the Kinghorn Centre for Clinical Genomics. She has genetic counselling and research experience and completed a PhD investigating psychosocial impact of genomic information, and Amanda also works on the My Research Results platform that we'll hear about today. So I'll hand over to Marianne Young initially, and so for questions, put them in the chat or hold them to the end. Thank you very much to both of you. Thanks, Marianne.
Thank you, and thanks for the opportunity to present this translational initiative that we've developed. And I thought I'd start by speaking first a little bit about how it was that we came to set this platform up. And then Amanda's going to talk about the actual platform itself. So we know that the boundaries between research and clinical care are actually diminishing, and there are some studies, research studies, that actually provide clinical information. And if you think about genomic research studies, we know that there are many, many genomic research studies going on where what we call incidental or additional findings are actually produced as a result from doing that research. There's been a lot of work done in regards to, I suppose, first of all, the ethics around returning that information, and also about how people think about returning that information. And there's a lot of evidence to show that both researchers and research participants in principle agree with the idea of returning research information. And what we're talking about is individual information that relates to that research participant, which is quite different from the way that research has been conducted in the past, where generally it's aggregate information that's being returned. So if we think about what are the benefits of returning genetic information, basically, to research participants, we know that that research participants themselves talk about this notion of clinical utility. And by clinical utility, we mean that the information actually makes a difference in regards to the clinical care for both the participant and their relative. Because what we're talking about being returned to people is what we call germline information, which is information, genetic information that can be passed on to people's offspring. So we know that this information can actually change the health outcomes for people, and that's how research participants describe it, that this information is of benefit to them and their family members. And we know that it's consistent with their preferences, that people want the information. There's another utility, which is called personal utility, which is that people think that the information is theirs and it should be returned to them because it does have utility. People have also looked at some of the harms in regards to returning genetic information to people and the potential for distress, the potential for discrimination and stigmatisation. And by discrimination, we mean things like insurance discrimination. And the other issue we have to think about is the harms of actually potential return of results that actually are incorrect. And you'll see in the platform that we're going to talk about how we actually address that. Because we know that when research samples are collected, they're not collected with the same oversight and governance than if a clinical sample's being collected. And we do have examples where there are erroneous results. There's also examples of erroneous results in the clinical space as well. If we go back to the National Health and Medical Research Statement on the ethical conduct in human research, the NHMRC statement says that researchers, when doing genomic research, must prepare and follow an ethically defensible plan to manage the disclosure or non-disclosure of genetic information. So the plan says that you can actually choose not to disclose at all, which is fine, or you can choose to return that information to research participants. The statement's there, but what is not in the statement is how researchers can go about doing that and what supports are available for researchers in regards to returning that information to research participants. Over the years, there's been many Australian studies that have returned research results. There's many international studies, but Australia has developed really a national process of how to return them. These are large population-based studies. You can see that most of them are in the cancer space, ovarian cancer, life pool is a breast cancer, colon cancer, sarcoma. So these are the studies where we've actually conducted research that's led to us setting up this nationally consistent way of returning research results. So what we did was when we returned the results, we actually went back and asked people what they thought, what was helpful, what wasn't helpful, were they distressed? And on the basis of that, we've used that information to develop this platform. What formally happened, so say when CONFAB, which is a big familial breast cancer consortium, say 20 years ago, what they would do was that they would write to their research participants to say, we are writing to notify you that a genetic change has been identified in your family. This information is important for your health and the health of your family. We strongly recommend you discuss this letter with a genetic counsellor or a doctor at a family cancer clinic. And then they inserted with this letter all the telephone numbers where people could go to access genetic counselling. But unfortunately, what we saw with that approach was that 40 to 64% of research participants, by just getting a letter, did not actually take up the information. And what we were hearing in our research interviews was that they weren't taking up the research information because of many systemic and logistic barriers. Many of them wanted the research information, they just didn't know how to get it. So if I start here just by showing you the pathway that people would go down, and what was happening that we were seeing was that the majority of people were not heading down this pathway. So they get their notification letter, they go to a clinic and have genetic counselling, they have confirmatory genetic testing, they then receive their results, and someone would then enrol them in what we call a risk management program. Some of the benefits that we think about in regards to returning this information is the participants themselves have described it as an opportunity. I'll show you some quotes in a sec from some of the research that we've done, but people talk about the fact that if this research hadn't been done, they wouldn't know that they were a carrier of this condition. So they see it as an opportunity. They don't see it as a negative. They see the information as empowering because they can actually act on that information. There are some people who've actually described it as life-saving. And most of the people in these studies would not qualify for genetic testing if they went to a family cancer clinic. So these are the people who don't have strong family histories, but they still carry one of these mutations. And we also know that the positive long-term outcomes for people is that they can engage in what we call risk-reducing behaviours. So to give you an example of that, if someone has a high risk of breast cancer, they can actually engage in more active screening, different types of screening for breast cancer. And some people would also consider risk-reducing surgery. Some of the positive long-term outcomes that we've seen is people adapt to this information over time and they do talk to their family about it. So they're the benefits that we see in regards to returning the information. So just an example of some of the recent interviews we've done with people. This person says, I now have empowerment to say, well, am I going to take a risk or am I going to lower my risk? What am I going to do? So this was a person who didn't know that they carried a mutation in one of these genes, and through research that was identified, the information was returned to them and they see it as empowering because they've got an opportunity to make decisions. So they say because knowledge is power. So without LifePool, I had no reason to suspect that I had this gene mutation. Some of the barriers that we know to people taking up this information is that they don't see it as being relevant. And that was when the letter was posted to people without an opportunity to talk to anybody. They believe that there could be a cost in actually pursuing this information. And we know that that's actually not true. There is no cost in regards to pursuing this information, but it's about providing them with more information about the relevancy of the information and the fact that there would be no cost. There are logistical and organisational barriers. So to give you an example, I spoke with a research participant yesterday who has rung the clinic 4 times and they haven't rung her back. So there are systemic barriers in the health system that are actually preventing people from taking up this information. People understandably have emotional and family concerns, and it is distressing to receive this information. So it's not to say that it isn't distressing for people, but what we can see is that people have unmet information and support needs, and that's where this program that we've developed actually fills that gap. And some of the other barriers is that people can be actually making uninformed decisions in regards to whether or not to take up this information. You can see that this was someone said they received a letter probably from this study about 15 years ago. The letter I showed you, the letter just seemed pretty general to me. So it didn't really say anything much, just, yeah, I think we came up with the consensus that we were just simply unsure. So the letter was vague and they didn't know what to do. An example from an Australian ovarian cancer study participant actually talked about the systemic and healthcare barriers to getting an appointment. I followed it for so long, and then I had to go a long way to another state capital to have this discussion, and I didn't do it. So it was all just too hard for them. And the reason I suppose we've set this up when you read statements like that is that with some advocacy, people will actually, if you can take those systemic and logistical barriers away, they do want that information. It's just that things get in the way for them. So I'm now going to hand over to Amanda, but before I do that, I just wanted to say what I've tried, I suppose, to talk to you about today is that researchers and the NHMRC and other research bodies and research participants actually support returning this information. We know that for researchers themselves, it's fine to have a statement from the NHMRC to say that it must be returned, but they actually don't have the mechanisms or resources to actually go about returning the information. And we also know that our research has shown that researchers actually do, research participants have unmet needs, and those unmet needs actually come about in the form of they need more information and they need support. And so that's what this platform is actually, has been designed to actually provide them with more information and support. So I'm going to hand over to Amanda now, and thanks very much for your attention.
Thanks, Amanda, that was great.
Yeah, so carrying on from where Marianne left off, the program that we've developed is a program called My Research Results. The program itself sits kind of independent of researchers, participants and clinical genetic services, but its purpose is to connect those 3 groups of people and help researchers to get genetic information through to their research participants. The program itself is led by genetic counsellors, which at the moment is Marianne and I, but we sit within various different groups who are providing support and have helped us to develop the program. So the program has been developed by Marianne and I, along with a steering committee of other genetic counsellors, psychosocial and genetic researchers, education specialists and some other clinicians. And they've given us really useful input, helped us to develop how we do things and, how we interact with different groups. We also have a genomic advisory committee that's made up of independent genetic counsellors, clinical geneticists and a genomic pathologist. And they provide us with really valuable clinical oversight, helping us think about, what constitutes a clinically actionable result, and reviewing difficult cases and those sorts of functions. And then supporting us again, we have our IT and data security experts who have been helping us with things like setting up our electronic record keeping systems, setting up our phone lines so that we can talk to people. And we've also been doing a lot of stakeholder engagement. So speaking to researchers, speaking to clinical genetic services, and most importantly, speaking to participants and consumers to make sure that what we're building really meets the needs of the different groups of people that we're trying to help. So the platform itself is really aiming to meet the unmet needs of researchers that have been outlined in some of the literature. Researchers have actually reported in published studies that they don't have the skills, resources, or time to effectively return this kind of individual genetic information to their participants. So we're here to, provide researchers with advice, support and resources to help them, first of all, develop an ethically defensible plan consistent with the NHMRC statement, and also execute that plan. So we provide access to genetic counsellors to actually interact with the participants and provide that support that Marianne mentioned is lacking at the moment in notification systems. And we also have our genetic expertise and the expertise of our advisory committee behind us. That can be really useful when you think about clinical actionability, because sometimes clinical actionability can be a bit different in the research setting versus the clinical setting. We're working with our advisory group to talk through what do we consider clinically actionable genes and clinically actionable results. For us, we're really talking about class 4 or 5 variants according to the ACMG guidelines in genes that we know have good evidence behind the risk management guidelines. So we're currently working off the ACMG 59 list of minimally reportable genes, and including a few additional genes for which there's clear guidance for management within Australia. We have our evidence-based notification systems. So as Marianne outlined, this is based on many years of research within the Australian setting. We're also going to build some online resources for participants that are going to be based on the outcomes of focus groups that we're currently setting up with research participants to find out if we were going to provide information online, what would they find helpful? And we also report back to research collaborators about the outcomes of the notification process, to close off the loop. Some of you may not be all that familiar with the role of a genetic counsellor, but genetic counsellors have been identified as a preferred or recommended partner in returning research results in this kind of setting, because we actually have specialist training in both genetics and health communication. So when you're talking about, sending clinically actionable information back to people who perhaps aren't expecting it, it's useful to have someone who has training in, communicating this kind of information clearly and sensitively. Genetic counsellors also get a lot of training and have experience in providing psychosocial support. So around those kind of emotional and family concerns that people have, we can provide support in that area. Genetic counsellors do a lot of practical support and advocacy work, identifying what resources and people need and helping them to get to where they need to be. Genetic counsellors provide decision support, making sure people make informed decisions that are consistent with their personal values. And we also focus on the individual, but also the family, because genetic information is often inherently familial, and sometimes people need a bit of help talking to their family about genetic information, what it means for them and what it means for the family at large. So genetic counsellors, I think, are a real asset of my research results, and it will be a really great resource for the researchers themselves as well as the participants when we think about sending individual genetic information back to people. Partnering with My Research Results is fairly straightforward. I mean, it all begins with deciding on to collaborate, having a discussion around, what the research group needs, how we can meet their needs, and we tend to formalise that in a service agreement, which we have templates for, so we can set it all up, outline everyone's roles and responsibilities, and then head off down the path of collaboration together. All the studies we work with need to have HREC approval before we get started, and get started with the recruiting of participants. The time of recruitment to a study is often a good time to talk about consent to receive research results. It's important to have a discussion around whether people want to receive results back, because some people would prefer not to have this kind of genetic information, and it's important that they have a chance to opt out of receiving information should it arise through the course of their research participation. That being said, some studies have, retrospectively gained consent to return research results if they've kind of done the research and subsequently realised, oh, we've got this important health information here, we'd really like to get it back to our participants. So there are different ways you can go about consenting people to receive results. Once the participants are all recruited, researchers tend to just go off and do their research and report on their research questions and outcomes, which is something that we don't need to be involved in at all. It's really when those clinically actionable results have been identified that they get fed through to My Research Results, and then we partner with the researchers to get those results back to people. And then, as I mentioned, feed that the outcomes from that back to the researchers as well. In terms of the actual notification process that we follow, it's quite similar to what Marianne outlined earlier. The process all begins with a letter, which still doesn't actually provide the specifics of the result that's been identified. And this is, again, an important step in the process because people's decisions can change over time. So this kind of gives people an extra opportunity to opt out of receiving genetic information. There's been some research that's shown timing and context or life circumstance can really influence whether people are ready or want to receive genetic information. So kind of having that soft approach initially means that we're not sending information to people that they might not want right now, or perhaps have decided they don't want it all. But the important part is that we actually follow it up with a phone call. So we've set up a 1-800 basically genetic counselling hotline. So now when the letter goes out to research participants, they're encouraged to call a genetic counsellor on the free call number directly. And so that call comes through to currently Marianne and I. And then we can go through and give people a bit of context about what the letter means, answer any questions they might have, and also offer them the results during the phone call if they want to find out right away. For people that want to know their result, we can tell them the result and then, send them off to a clinical genetics service where, again, they can have their confirmatory test, which is still very important, receive their results and then have appropriate risk management. Some people have wanted to receive their results in person, in which case we can, again, refer them to a genetic counselling service and provide the information to the service so that people can have a face-to-face discussion if that's what they prefer. But again, we can be there to identify what's their local service and what's the easiest way to get them in. And we may still have some people who, after having a chance to discuss with us and get a bit of information about why they've received this letter from the research study, some people may still choose not to take up the results, and that's perfectly fine. But we're really there to make sure that if they do choose to decline the results or the genetic information, that's a choice that's made with adequate information and support. And we can also sit in the background because we keep records as a medical record, a genetic medical record. People can come back to us in the future if they change their mind, which is an option that they may not necessarily have if a research group or a study has closed down and there's no longer a contact for them if they did change their mind in the future. So, having my research results sitting around this notification process, we think, well, based on the research, we understand is really helpful for people. There's been really good feedback about having access to a genetic counsellor right away. We know that this can be a particularly unsettling time for people because there's still a lot of uncertainty around, you know, is this a true result? Because there's always that confirmatory test that people have to get through before they can actually access any, you know, additional screening or other risk management options. So the feedback that we've had on this system of using the letter with the phone call has been really positive, and that people really appreciate having that access to someone who can provide that support during that time. We think that there's definitely benefits from a bunch of different stakeholders from this service being provided. For researchers, it means that there's a nationally consistent approach or a way for them to, you know, meet the NHMRC recommendations for having a plan for managing these results, which means that they don't have to come up with ad hoc systems and, you know, have a less systematic way to do it, which hopefully will save researchers time. And there have been some reports that it's actually caused researchers, you know, a bit of stress trying to figure out how to get this information back to people in an appropriate and sensitive way. By doing it this way and centralising the expertise, we'll have genetic counsellors who have experience in this kind of area. It also, the trouble that we have with genetic counselling workforce is there actually aren't that many of us, so there's not necessarily capacity for each study to have a genetic counsellor or a genetic expert working for them. And often genetic counselling expertise isn't needed for the duration of the study, so having a centralised service that you can dip in and out of at the time you need it, we hope will be very helpful. Our service is based on best practice. It's based on Marianne's many years of research genetic counselling and what has been shown to work and not work across many years of returning results to participants. We operate very flexibly. We've started collaborations with a few research groups, and already we've seen differences in you know, what people have needed and how we can best operate to meet their needs. And we're actively seeking feedback from all the different groups. So we hope that the service will be, you know, continuously improving with time. We've also already had some opportunities for additional research collaboration open up with different groups that we're working with, where we've been able to explore different outcomes from their research that they perhaps hadn't considered when they started out on their research. We see particular benefits for participants, which I think we've kind of touched on throughout our talk, but generally better access to research results and health information is a big one, partly because more researchers will be able to return results to participants if they have, you know, the resources and support to do that. And also we're operating entirely via telephone counselling, and we'll have resources available online. So for research participants, they should get the same access to research results no matter where they live, whether in the country, the city, it should be all the same. That information and support from the notification to the clinic appointment is a really important one, because as I said, that can be a really stressful time for people while they're waiting to find out what this information means, have their results confirmed and be able to actually take action on it. People often feel a lot better having got health information when they can feel they can really do something about it. The support to make informed decisions is really important because, again, we don't want people not taking up really important health information just because they couldn't get through to who they needed to talk to or they didn't have enough information at the time. We do have online resources planned that are going to be informed by focus groups with research participants. And again, that advocacy and practical support, so identifying their local clinic and helping to you know, really drive an appointment and get them in there as soon as they can. There's also the opportunity to access the results at a later date if right now is not a good time, or if they change their mind in the future, which has come up in previous research that sometimes people think it's a one-time offer, and so they never reopen that option when they might have actually come back had they known they could get it. We also think that My Research Results has benefits for clinical services. Being genetic counsellors and having worked in the clinical area, we can send referrals or arrange referrals that have all the information that the clinical services need to see a research participant for confirmatory testing, which will save them a lot of time running around trying to collect reports and information. Speaking to the participants before they get sent through means that the participants or patients will be better prepared for their appointments, and research has shown that that has positive outcomes for health appointments. We can be one point of call for the clinical services to access information, so they won't have to contact researchers. And this could be a way of identifying people who are appropriate to be seen by clinical services and represent an alternative pathway to genetic testing. So a bit of information about our current collaborators. The Cancer Council Victoria and ASPRI are two of our very early ones, where we're probably the furthest along the line. And I'll go through those in a bit more detail. We're also working with the Kirby Institute and St Vincent's Hospital to recruit people to some COVID-19 genomic research, trying to look at genetic factors influencing COVID response. And that's been really interesting work. We're also going to be working with the Australian Parkinson's Mission and also the Centre for Population Genomics. The thing that these studies have in common is that there's no existing clear mechanism or clinical way for them to get the results back to their participants, which is why our service has been useful for them. For the Cancer Council, I mentioned that some studies have gone back and retrospectively consented participants to receive information. This is one of those studies. The Cancer Council have sent out 4 notification letters to let their participants know that there's genetic information available. And we managed to get in touch with all 4 of those participants within days of the letter being received, which is one of our key goals. 3 of the participants so far have called us pretty much right away after receiving their letter. So within a couple of days, they were on the phone to us. And those 3 people decided they wanted to know their genetic information. 2 of those results the participants were already aware of, and we contacted their clinical service to confirm that and make sure it's definitely the same result. So there was no further action needed for those people. And the remaining person has been referred to their local clinic to have a confirmatory test. There's a conversation ongoing with the 4th participant. We made an active call to her because she required an interpreter. So we're still speaking with her and making sure that helping her to decide and what she wants to do. But it was a very interesting experience. The first 4 participants that we had, we needed an interpreter in the first batch. So we quickly got set up with an interpreter service and kept the ball rolling with that. ASPRI is a very large cohort of what they call elderly individuals. So they're elderly people who've been recruited on the basis of their good health. They've done their genomic testing on people and have 32 results that are clinically actionable and appropriate to return to their participants across BRCA1 and 2 and some of the cardiac genetic genes. We're about to start sending notifications out to ASPRI participants, but this is one study where we've slightly adapted our systems because ASPRI needed to get consent to share information with the My Research Results service. So there's an additional contact from an ASPRI representative in there, which also meant that we could set up a booking system so the ASPRI representative can book people a time to talk to us so they know exactly, when they're going to be called to talk about the genetic information further. ASPRI were also interested in the experience of their participants receiving this information from the research study, because they're kind of a unique cohort, elderly people undergoing genetic testing, and there may be less of an impact on their health for the information and more of an impact on their family. So we worked with ASPRI to develop a qualitative study to explore their participants' experiences, and we're going to help them see that study through as well. We have a lot of future plans for the service. a lot of building of online systems. We're hoping to put together a patient portal that will give people access to their genetic information online. We're working with some groups to work on a dynamic consent module, which will help us to consent people and make sure that we have up-to-date consent information for people when thinking about returning results. We're working on some health economic studies and cost effectiveness studies to show that this is a useful and cost effective service. And we're just going to be constantly improving the service based on feedback from our collaborators, from participants, and also based on our experience. So a lot of work to be done still, but we're certainly getting there, and we're excited to be returning research results to people. And this is just our final slide with a bit of information about the service and some contact details in case anybody does want to get in touch with us or has any questions that we can't address while we're on the call.
Thank you very much, Amanda and Marianne. That was fantastic. Look, I'm going to obviously open the presentations for questions, so people are very welcome to either pop a message in the chat if they'd like to ask a question, and I can already see Amanda has. No, so it's Candice has put a question in, but it looks like it's Candice. So look, I'll start with Candice's question because she's put that into the chat. I think I've got a couple of others, but I'm sure we'll have lots of questions, but we do have lots of time, which is great. So Candice Carter from the Biobank has said, speakers said that the pathway for participants to receive results include face-to-face appointments. If there is no cost to the participant, just how are the services funded? I think I was going to ask that similar to you.
So the genetic services in Australia are publicly funded, and genetic testing is publicly funded as well. If you have a family history and you go to a genetic service, there are criteria that you have to meet to have genetic testing, but these people already have a genetic testing result, even though it's in a research setting, but they can access the services free of charge. It's all Medicare rebatable, and they're funded from the state and federal government.
So I guess just to follow on from that, is that in terms of researchers that are working with my research results, is that a collaborative model? Does that involve any cost from the research partners? It's
a really great question, and Amanda demonstrated that we're actually doing some cost effectiveness. We're about to set up a study to look at cost effectiveness, and we want to look at actual cost per participant to actually return the information, because the My Research Results platform is philanthropically funded, and our positions are philanthropically funded. That's ongoing funding. And we would like to understand how much per participant the cost is, because we are talking to the NHMRC. We are in consultation with the NHMRC about when someone writes a grant and they are expecting that they'll return genomic findings, do they actually need to put something in the grant to financially support that? So at the current stage, there is no cost to researchers, but down the track there may be, and it's likely there will be, but we are yet to determine what that cost would be. And we are also working with granting bodies. It's not just the researcher's responsibility, it's broader than that. Yep.
Yeah, and I guess there might be opportunities for researchers to write support into, for My Research Results into their grant applications as well.
Yep.
We've got another question in the chat from Paula Kazi. It's great, important work. Thank you.
Want you into that one?
What's your current opinion about what genes should be returned to biobank participants, e.g. all ACMG59 genes or a subset?
Yeah, I mean, we're not entirely prescriptive about what should and shouldn't go back. At the moment, we are working with our advisory group on a list of genes which is going to include the ACMG59 most likely, and possibly a few other cancer genes that have clear guidance recommendations on EVIQ, which are the national standard cancer risk management guidelines for Australia. So I think it's not for us to say what researchers are comfortable giving back and not, but it's more that we would be less comfortable giving back results that would be outside of the ACMG 59 and things that have clear guidelines.
And I suppose we talked about that notion before of personal utility, and there are some people who would say, well, I want everything, but we're not able to do that. We are being guided by national and international guidelines around information to return to people.
No, absolutely. Look, people are very welcome to sort of raise other questions, but I've got a couple of others. But one of them I was interested in is this concept of people, obviously wanting to, they might not want the information now, and it might not be relevant to them now in terms of, their disease and their life stage, but they might want it later. I was just wondering, it's a very, I think it's a great aim to be able to return results later. But I guess my question is, in terms of the research, what are the time frames that people want information over? And you make that actually possible in the real world? Like someone wants something 10 years later, in terms of just continuity of operations. Has that been achieved in any other settings?
I'm not sure that it has in the research setting. K-Confab might be an example where people have done that because they're a very long-running group.
It is. It happens in the clinical setting, like when both Amanda and I have worked in clinics for a very long time, and that you would have an arrangement with we call them patients, but the person, and you'd come to an agreement that they didn't want it now, and when would they like to have another conversation about it, and when would be a good time to call. So it may be that you agree that you call back in 3 months, 6 months, or 12 months, but that they're welcome to call you at any time. And so we would operate the same way with the My Research results. If we identified, I'll give an example. We had a research participant that was going through a divorce, and it wasn't a good time for her. And so came to the conclusion, not a good time, it can wait. When would you like us to ring you back? 6 months. So we put that in our database, and in 6 months the flag comes up, ring this person. We go back into the notes. The reason we didn't, she asked us to ring her back, see how things are. Yes, it's a good time, or no, can you ring me back in another 6 months? So we do have that longevity of, I suppose, contact with people.
Yeah, no, that's really great. Look, my other question was, I think you both raised, there's not really many genetic counsellors, and I'm aware of that through my research. So I guess the question is, are there sort of efforts underway to try to train more genetics counsellors? I think I understood that it was an intake at the moment of every second year. Is that right in New South Wales?
Every year.
It is every year now?
Yeah, so the University of Technology Sydney offers a master's degree, and it's every year, and Melbourne University the same. And so, yes, there is a workforce shortage, and it's really good in a way in the sense that it's encouraging people to think about working smarter. So I suppose if you think about My Research results, what we've done is we've distilled the research evidence to find a smart way to work and set up a national program rather than having programs in each state, and we will be able to address the workforce issues as we go along. So we're just about to recruit another genetic counsellor to come and work with us because we are starting to really ramp up now. So it's an evolutionary thing. But fortunately, Amanda and I have worked in clinics a long time, so our clinical practice is really informing this as well. Oh. The good old PRS.
All right. So, yes, look, I think that's a really smart response. Sometimes shortages of supply makes you be a lot smarter than you would be otherwise.
Yeah.
So yeah, we've got another question from Paul about returning PRS results, which to be honest, I can't tell you, I don't know what that is.
Polygenic risk score.
Paul, you're being controversial. Okay, so one day it is quite feasible that polygenic risk results will be returned to research participants. As yet, we don't have the national guidelines in place to do that. America and the US are just putting out some guidelines at the moment. This is a very topical sort of conversation, as Paul knows. Yeah, I can see one day, I might be retired by then, but I can see that one day PRS will be important information to return to research participants, but it may not be clinical genetic services that do it. It may be more the remit of primary care physicians or whatever. Yeah.
It's always good to see some controversial questions, I think. Does anyone else online have any questions? I do have a bit more time.
Is that a hand up?
Oh, Judith has put her hand up. Judith, do you want to go ahead and
yeah, sorry, I'm trying to figure out how to do this in Teams. Yeah, no, thanks for the talk. It's a really great service that this is coming together as a nationally consistent approach for this, because it's always been a hairy topic in biobanking and also ethics review for different projects. A couple of things I was thinking about, and it may be due to my lack of knowledge in genetics. As a reviewer for HREC, sometimes there's opt-out when the researchers are effectively also the kind of a clinical research setting, and when it's regarded as important health information, are there situations where there becomes sort of a tension in the role of the clinical researcher in the case of an opt-out?
Can I just clarify?
The second thing, I'm sure there's fuzzy things where there's not clinical guidelines where there's a genetic result. Are there situations where they can get results later if the science has moved on and it becomes a result that has a clinically, reviewed kind of guideline?
I mean, I'll tackle your second question first. I think a lot of that would come down to research protocols and whether the research group intends to or has capacity to review the sequencing data over time and update results. So if researchers were inclined to revisit results over time and update them, then things become clinically actionable according to what we understand and what we give back, then from our perspective we would welcome returning new results. I think the question, and it's still a question that's being worked out, is do researchers have an obligation to revisit results and review results over time, or can they leave it as kind of a one-off thing? I think either way you want to do it personally would be fine, and I think as long as it's clear for the participants whether or not this is likely to be something that remains open for 10 years or not, because the longer the time goes by, people tend to forget about it and not expect it anymore. So I think you need to be clear on that, because otherwise you can end up in a very, like you said, kind of hazy, fuzzy area where you're not sure where your obligation lies. So I think being really clear about that when you start out on your research, what you're willing to do and what you're not, and where you draw the line, helps with that.
And I think what you've raised is really interesting in the sense that even clinical genetic services don't have those sorts of guidelines in place. Even laboratories don't have those guidelines in place. And I think it's now just with the evolution and people realising the longevity of genomic information and what is the responsibility of people. And I think internationally and both in Australia, this is actually, this sort of conversation is starting to happen. And if you think about it very pragmatically, if it was the responsibility of the researcher, they'd never be able to close down the research project. And that's a burden that is not okay to lump onto researchers. There has to be a close date. So, you know, my research results or some form of platform could actually take that on, but we don't actually analyse the genomic information. We deliver the information that the researcher gives us. So it's tricky. It's really tricky, and you've raised a really valid point.
Judith, I think you had a first question.
Oh no, that addressed both of them. Yeah, it's both really about the fuzzy lines, both in the research context and especially as precision medicine, and when it's more integrated in a clinical environment. I do wonder about the hard opt-out that is on some of the hard copy consent forms. And it's great you've got that soft approach on your platform, but yeah, you wonder about the informed decisions people make once they are notified of a result, but whether that sort of support comes when they decide to opt out at the beginning.
Yep. And look, you know what it's like when you're consenting someone. There's 50,000 things to go through on the form, and it's really hard to say to someone, so they say they want these findings, to actually say, well, do you really know what that means? Because sometimes you can't know what it's like until you actually do it. And I think that's what this platform offers is objectivity around the fact that there may be some people who don't want that information, but it's enabling them to actually say that and to say it's okay not to have this information. And you can come back to us another time if you want. At the moment, we're not seeing a lot of that. It's almost like it's there, so I've got to have it, it's mine. And so it's a matter of supporting people through that process. But there are some people who decline. Yeah.
Any other questions? Aha, Paul. One idea for the future could be from my results to add a variant curation service.
Yeah. Do you want to talk about the US clinic with Les Barsecker?
Yeah, I mean, there is a clinic in the US that kind of has the same goal, but actually receives raw sequencing data from the research groups and does the analysis and variant curation to identify the clinically actionable results. So the researchers don't need to be responsible for that aspect of it at all. That particular model is very resource and labour intensive. We are probably going to have some kind of support for variant curation approval with our advisory committee, if that's something that researchers need, and we can discuss that with people who are interested in collaborating. And that was part of the reason for setting up our advisory group in the first place. But yeah, it is a really interesting idea. And there are some people who are looking to, you know, go even further than that and actually do the variant curation themselves or search for the variants in the first place. The difficulty with that is they also do the confirmatory test on a second sample, so they're limited in that they can only offer that particular service to collaborators within their research institution, and they need to have access to the participants. So we've taken a slightly more hands-off approach so that we can be available to more researchers and more participants at this point in time, rather than providing, you know, a more intensive service to fewer people.
Thank you. Yeah, that's. I guess, you know, having been involved with variant curation, it's certainly not a straightforward exercise, and it's not really something that you can apply a one-size-fits-all approach to. So I think
it would be great if there was some automated system that the genomic data came into and it spat out the class 4s and 5s and got rid of the others. It is, and having worked in a commercial laboratory, it is the most labour-intensive, complex thing I've ever seen in my life. Yeah, it's very complicated.
really hard. And it's almost one of those things that I think the hive mind can work on. Like, you actually need to talk to a lot of people and get a lot of opinions.
Yeah.
It's an interesting, when I've been involved with that, it must mean, you need a big team of people to talk about stuff. So, yeah. Anyway, I'm watching the clock. We've only got 2 minutes to go. I think we might wrap things up, but just, that was a wonderful talk, a fantastic service. And I think you've given us a lot to think about, and, just congratulations in setting up the service. And, it's quite possible that we'll talk to you about this further offline. And, just, really great presentations today. Thanks so much for your time.